So thalidomide was a great start for our IMiD therapies in myeloma. However, now with lenalidomide and pomalidomide and the new cell mods coming through, I don't think thalidomide's used very much, at least in the U.S. Again, great homage to the history, but not so much anymore clinical use. So BCMA therapies are phenomenal, but of course, we really want to monitor patients for toxicity. And there's lots of different kinds of adverse events that we see, specifically to BCMA itself, whether it's the antibody drug conjugate or the bispecific or the CAR T, because BCMA is also on earlier line normal plasma cells and potentially mature B cells. One of the biggest things we see different from other antigens for myeloma is really the hypogammaglobulinemia. And so this is why it's so important that when we are seeing patients who are relapsed refractory with low IgG levels, that we continue to give IVIG, especially if they're getting infections. Our patients are now getting, these infections that we wouldn't have seen before because of partly of the hypogammaglobulinemia. And then, of course, with CAR T and bispecifics, as we've talked about before, there are things like CRS and cytokine release syndrome and neurotoxicity, not things that usually happen after 30 days, but infections, I will say, is the biggest piece that we have to monitor for. So, BCMA, again, amazing find for us for myeloma, because it's on myeloma cells and almost all myeloma patients have it. It's about 95% of patients will have BCMA expression. And because it really starts from patients who even have MGUS and smoldering disease all the way to relapsed refractory, it is one of the universal antigens we found for myeloma that, again, why everyone is attaching different things to it, like an ADC or a CAR T or a bispecific. There are other antigens out there, like GPRC5D and FCRH5, which, are earlier in evaluations in clinical trials like phase 1 and 2 right now, that do have some pretty phenomenal responses, and I'm excited about them. I don't know if they're going to be better than BCMA. What I'm excited about is combining them, maybe sequencing them to hopefully get all the different myeloma cells gone. We don't know much yet about BCMA expression being consistent, amongst all clones of myeloma. And most people will have more than one antigen. And again, BCMA is involved in the actual proliferation of myeloma. Any antigen that we have to make sure we see it in most patients and in myeloma cells. We can kill the most myeloma, but also not on other targets, normal tissues. And so again, BCMA is not on too many other normal tissues. So the side effects are a lot lower than other potential targets like SLAMF7, for instance. So I am so excited to be working with all of our primary care providers and oncology community doctors here in the Houston area and Louisiana and sort of everywhere, because we've created this pathway for patients to get in for clinical trials or novel therapies that they might not be able to get locally. And then we have this partnership where then I can send them back to their doctors to, get other standard of care therapies that they can get back home. And I think that's brought so much more access for these new treatments, but as well as, what do you do right before the CAR T? What should I not do? Avoid things. And sometimes when you're not specialized in it, you might not know, well, that's all I do all day long. So, really making sure as a group, as a team, we take the best care of these patients. And I think the earlier you send them to us, even at diagnosis, even if they're smoldering, that helps us really be engaged with that patient. They come back and forth through their entire treatment course rather than just a one-time. I think that will give them the best outcomes. So always when we have these new therapies, it's really exciting. But then we start coming into the logistical issues of insurance approval. So for standard of care, we've actually done really well with both bispecifics with teclistamab, as well as CAR T, cilta-cel, and ide-cel, at least getting approved with all different kinds of insurance companies. I haven't had too many problems. But then when it comes to sequencing therapy, we haven't had issues yet of being able to give, let's say, teclistamab now for patients who have already gotten the CAR T before or the ADC, or vice versa. When there are different mechanisms of action, I haven't had trouble. However, what I do know is, a lot of my patients who have had CAR T once really like to get CAR T a second time. That one and done is such a big deal for them in terms of their quality of life and sort of feeling normal again. And I've had times when it was approved for a different option, or if they had a clinical trial and then we're doing standard of care and we were able to get approval. But I've also had instances where we couldn't get it approved, even though it was a different product and it was a clinical trial before. And, we gave all the evidence that we could. We have some, retrospective data that shows that CAR T could actually still be really good after one CAR T. So this is an evolving process. And I think hopefully we'll be able to advocate for our patients to get all things approved for them. But sequencing is a little bit unknown. I will say the one time that I'm really worried about is if you try to do a bispecific first for many months to years, and then try to do a CAR T right after, we're probably going to see some manufacturing issues. And so really there might be a time difference, or maybe we can learn how to make the T cells better again before we try CAR T. So a lot of us are working on that for research. So myeloma, thankfully, we don't just do skeletal surveys anymore in terms of imaging because we're missing a lot of early disease in the bones. And really, it's PET scan, a PET CT whole body from top to bottom, unlike in lymphoma where we just do it sort of to mid leg. But MRIs are really helpful as well. We have this thing called the whole body MRI bone marrow, which looks at the bones as well as all the bone marrow. And it does help let us know if there's certain lesions in the marrow itself, that are a certain size. If there's more than one, then we call it myeloma. I will say that I prefer to actually have bone marrows. If I'm really looking to see what's happening in the bone marrow, I won't use an MRI instead of a bone marrow biopsy because I want, all the other information that I can get if I needed for the plasma cells, like their genomics and really what % are we seeing of the myeloma there. However, if it's just to see if they need to go from smoldering to active myeloma for treatment, then MRI is my go-to imaging, especially if I'm looking for lytic lesions. I think the MRI is a little bit better than the CT portion of a PET CT. However, a lot of patients can't do MRIs. They get claustrophobic, and so PET CTs are a great alternative as well. So yeah, I think CAR T and bispecifics in the relapsed refractory we've shown have done some amazing things and really revolutionized our treatment for these patients who a lot of folks would have been in hospice, and now are living years because of the fact they got these novel therapies, which is huge. Clinical trials are currently ongoing with early line therapies. We have the KarMMa-3 data that was positive as a prospective study. And then now we have CARTITUDE-4 coming out at ASCO, and I think will be positive as well. We'll find out soon. But I'm hoping that those will lead to earlier line. I think it'll be in second line, likely, second and third line in the next 6 months to a year. And the current trials looking at first line therapy are ongoing right now, are about to start. So I do think in the next 5 years, especially for our high-risk myeloma patients, we'll be using CAR T at least second line, if not, as consolidation and first line after induction therapy. And I think for standard risk patients too, we know that when patients that are high risk do really well, standard risk patients end up doing even better. So is this the way we're finally going to get a plateau for some of our patients by getting CAR T in early? And I think the 5 years after that, it'll be how do we combine this in early line to get a better plateau? So molecular profiling, for myeloma isn't probably as well understood like it is in AML, where, we have an 81 panel and we have drugs that go after different pathways in a patient's AML, but it's still really important in myeloma. So we know that FISH, for instance, in myeloma really tells us someone's high risk or if they're standard risk disease, and we might treat them differently in terms of their induction. I push them for transplant if they're high risk, and then I might even do more than one drug maintenance for those patients. Those are also the patients I try to get to CAR T or bispecifics early, especially on clinical trials if they're available. But then further molecular profiling, like things like NRAS and KRAS and CCND1, there's two reasons I usually do it for my patients right now. One is if the FISH, for some reason, they weren't able to do it correctly and we missed something like the translocation 1114. If the molecular profiling can find CCND1, then I know that patient might have translocation 1114, where I can actually give them a drug, venetoclax, specifically for that mutation. Same with NRAS, KRAS, the RAS mutations, the MAP kinase pathway. We do know that there are drugs that we use in other cancers, solid tumors, that could work. We don't have as much data on that and prolonged response that we've seen with it, but I do think in the future, we're going to have more of these targeted therapies with our novel immune therapies, and really that molecular profiling will come in handy there. And as we learn about more molecular changes and hopefully new targeting drugs, it's going to be more and more important down the road.